Hello, everybody, and welcome to the IOCDF Research Roundtable, a roundtable where we pick an interesting topic within the OCD literature and discuss it with the folks that know it best. Today, we have a very special roundtable. It's co-presented by the Tourette Association of America. We're going to be talking about the overlap between OCD and Tourette's, which honestly, as I was kind of reviewing articles before doing the stream with you all, I was most surprised that we've never talked about this because the overlap seems really big and there's a lot of connections. And honestly, they were pretty confusing. So I'm very thankful to have a panel of experts to ask questions to. My name is Kyle King. I am a first-year medical student at Yale University. I am an international IOCDF advocate. And more importantly than both those two things, I'm someone who has OCD. I was diagnosed when I was 13. I've lived with the disorder for most of my life. And a lot of things that we discuss on the show apply they're very personal to me. My co-host Jonathan Abramowitz is going to be with us today. I feel like he has some meeting or conflict. He's a busy guy. But we have an excellent panel of people to discuss this topic with, so I'm sure we'll have no shortage of conversation. Before I introduce our panelists, John keeps moving in and out. I have a few announcements that I have to make first. First, this live stream is educational and is not intended to replace therapy. For treatment-related questions, please work with your provider or contact a local clinician. You can use the IOCDF's online resource directory at iocdf.org/find-help to locate a trained clinician near you. Also, the IOCDF is not a crisis hotline. If you're in a crisis or if you're ever feeling suicidal or unsafe, please call 988 Suicide and Crisis Lifeline by dialing 988 or call your local emergency room at 911. Second, this is a live stream, as the name implies. We want to create a safe space. There is a live chat function. We love when you put questions in there. We love when you put comments in there. I will try to address as many audience questions as possible throughout the stream. Just remember, we're all here to support one another. And this is broadcasted onto the internet and will live there forever. So be respectful, be kind, though we've never had any particular problems. And finally, kind of a fun announcement, applications for the Research Grant Award at the IOCDF are open now, and you can apply, and they're due by February 28th. Also, symposium and poster submissions for the upcoming conference in Chicago in 2025, the summer 2025, are open now, and they're due by February 3rd. All right. That's enough announcement stuff. Let's get introducing our guests. I practiced all my pronunciation about 5 minutes ago. Let's see if I can go 3 for 3. The first biography up on my screen is Nora Strom. Strom means electricity in German, which I just learned. Nora is based at Humboldt University in Berlin with tight affiliation to the University Clinic in Munich, Aarhus University in Denmark, Karolinska Institute in Sweden, and Dalhousie University in Halifax, Canada. She has a background in cognitive science and neuroscience and is currently finishing her PhD with the topic of genome-wide association studies of OCD and related disorders and symptoms, mainly tic-based and hoarding disorders. Nora, how are you doing?
Very good. Glad to be here.
I did well with the pronunciation.
Yes, you did. It was very good.
Our second guest is Christine Conelea. Dr. Conelea is a clinical psychologist and associate professor at the University of Minnesota, where she leads the Minnesota Tic and Compulsivity Lab. Her research focuses on novel assessment and treatment approaches for tics and compulsivity using integrated behavioral, neuroscience, computational, and patient-centered approaches. Christine, how are you doing?
I'm great. I'm so happy to be here.
Yeah, we're super happy to have you. And last but not least, we have John Piacentini. Cool.
Right.
What? Not bad?
Not bad at all.
I'll take that as okay, cool. John is a professor of psychiatry and behavioral sciences in the David Geffen School of Medicine at UCLA and the director of the Child OCD Anxiety and Tic Disorders Program and Tourette Association of America Center of Excellence at the UCLA Simmel Institute. His research focuses on the development and dissemination of treatments for youth with tics, OCD, anxiety, and body-focused repetitive disorders. John, how are you? There's a little delay on John's end. Was he frozen? John, blink twice if you can hear us. Okay, I think he might be frozen. He'll come back online soon, hopefully. In any case, we have an awesome panel. of people who know a lot about this topic. Well, hopefully John will be able to reconnect soon, but in the meantime, we'll get started into the research. So the first question that I had, just because I know, oh, I see John moving again. Hey, John, can you hear us now? Nope. Okay. The first question I had, and this is for either Christine or Nora, just kind of like, what are tics and what is Tourette's? Are they the same thing? Are they different? Just some general clarifications.
Sure, I'm happy to take that. So tics are the hallmark symptom of Tourette syndrome, and tics are involuntary movements and sounds or vocalizations that often happen rapidly. They tend to be quite frequent. Like our research shows, most people have them about like at least 8 times a minute. So these are very frequent movements and sounds. And from a like technical definition perspective, Tourette's is the diagnosis that someone has if they have a history of both the movement tics and the sound tics. Whereas if they only have one or the other, they would get a chronic motor or chronic vocal tic disorder. And those are the diagnoses we give after someone's had tics for a year. If they haven't yet had tics for a year, we call it provisional tic disorder. And we used to think of it as a more like transient childhood disorder, but more and more based on our research, we know it actually tends to be pretty persistent for people. And even if the tics get better, I'm sure we'll talk about this more in the stream, but tics are really just the visible part of Tourette's. There's a lot of other kinds of brain functions that are impacted by the circuitry that drives tics. So a lot of folks, even as adults who may not have as many of the tics themselves, might experience some of the other aspects of the syndrome.
I mean, it seems like a good place to ask. What are these kind of other aspects of the syndrome?
Yeah, so, essentially the brain systems that are driving tics are involved with movement control, with our ability to inhibit, so sort of putting the brake on movements or things impulses that we have, and then also the circuits that kind of connect together emotion and movement. These are also like the same circuits in OCD. And so because they touch so many different functions that the brain does, we see a lot of it's kind of depending probably on where the individual is experiencing differences in those circuits kind of drives probably what their symptoms are. But some of the most common things are OCD. So about 30% of patients who have Tourette's also have OCD, and other kinds of like repetitive or compulsive behaviors or body focused repetitive behaviors. There's very high comorbidity with ADHD. So about 70 to 80% of people have ADHD. And there's also high rates of autism. And then there are some other disorders that we think of probably more as coming online as a consequence of some of the difficult experiences that people might have navigating the world with tics. So things like depression or social anxiety that might happen because someone's like, avoiding social situations or withdrawing because they're in an unsupportive environment. So kind of we think of them as like the more like biologically driven part of it, and then the sort of the how the environment impacts someone's functioning.
Yeah, that's fascinating, and I can see kind of immediately at least if we take kind of this slice of neuroscience, how it may connect to OCD. John, just to catch you up, we're talking very generally about what tics and Tourette's are. Are tics transdiagnostic? Like, do we see them in kind of like a number of different syndromes?
Yeah, we see tics across a lot of different syndromes, mostly neurologic symptoms after injury, but tics are pretty common behaviors in development. 20% or more of little kids, kindergartners, first, second graders experience tics. We can experience tics when we're stressed, when we're tired, getting that random eye blink or a little twitch or a movement. A tic disorder is really only when the tics rise to the occasion of being interfering or disabling or distressing to the individual. And then Tourette's is even a more specific case. You may have said this already. is the presence of both motor tics and vocal tics, two separate kinds of tics. But tics are ubiquitous across development and across people.
Yeah, and kind of, can you give me like examples of what tics might be? Because I was reading and it seemed like there's complex tics and then I suppose implicitly non-complex tics. So kind of how does this present?
Would you like me to answer that or someone else?
Anyone who knows.
So we think of tics are basically kind of discrete, rapid, non-functional behaviors. So what does that mean? It means, things like an eye blink, an arm movement, a finger movement, arm thrusts are pretty common, head jerks or head rolls, facial grimaces. Something like that really doesn't serve any purpose, but it's a behavior. We have foot stomping, maybe extending the foot, even kicking, stomach tensing, abdominal or pelvic tensing or squeezing. There's almost an infinite number of tics, almost any muscle in the body.
Yeah.
Yeah.
And can they involve like repetitive behavior, something like what you see in OCD?
Yeah, I mean, this is like, I find this like such an interesting area, both clinically and from research, is there is this, we like to try to put these categories on things that aren't actually like categorical in our
run into this a lot.
Right, exactly. And so like there's this huge, like there's this intersection of OCD and tics that are just these like, they're behaviors that are involuntary or like semi-involuntary, like they feel difficult for people to control, that are preceded by often these more like sensory experiences than you have in like harm avoidant OCD. We think of as like, there's maybe a specific thought of like something bad will happen if I don't do this behavior. But we have both these kind of complex tics and compulsions that fall in this gray area where there's maybe more of just a sense of like incompleteness or something's not just right. Like I just need to do this, open this drawer over and over until it feels done. And there's not like a fear behind it. And so those kinds of behaviors can be really tricky to sort of know what diagnosis we put on it. And they actually tend to be a little harder to treat because our treatments were built more on like these being separate categories.
Yeah, I don't know if anyone has anything to add because I certainly have questions about that overlap.
Well, there is, Kyle, I don't know if you're going to get to this or not, but there is a syndrome, for lack of a better word, called Tourette OCD that was first coined by Charlie Mansueto, who's been a member of IOCDF for quite a long time. And it's kind of the exact interface of Tourette's and OCD. So it looks kind of like Tourette's, looks kind of like OCD. The movements or the compulsions seem to be triggered in the same way a tic would be triggered by an unwanted kind of sensation, but they need to be done like counting a certain number of times or tapping a certain number of times. But the behaviors aren't done to make a bad thought go away. They're done to make a sensory feeling go away, so it's kind of like the trigger is Tourettic and the response is more like OCD.
Mm-hmm. When you guys say that like the trigger is Tourettic or it's the sensory experience, is that like, I guess, what does that mean exactly? Like, will someone just be sitting, studying, reading, and then they'll just have the vague feeling that something needs to move?
It can be externally triggered or internal. Like some folks describe things like, oh, if I, bump one arm against something, I have to bump the other arm to feel even. Or like I've worked with folks who, again, it's about maybe readjusting something or redoing a behavior until there's like a sense of completeness.
Mm-hmm.
But I think it tends to be more like, like John said, it's this more like sensory quality of like, if we think like, all of us have like an urge when we like are about to sneeze, or if you hold your eyes open for a really long time, you do start to feel an urge to move. And that's like sort of more how people describe this.
Mm-hmm.
Maybe I can jump. Oh, sorry.
Yeah, go for it.
I just wanted to jump in with regards to the tic-related OCD, because that is actually a research project that I got funded by the IOCDF, and I'm doing right now. Don't have any results yet, but we actually want to look at. My background is not clinic, so I let the other two speak on symptoms and all of that. So I look more on the genetic side of things. And we currently look at how Tourettic or tic-related OCD might be different from OCD and tics by itself, and kind of disentangle the genetic underpinnings of both, or having both at the same time. So there might be people that generally have both disorders as well and are just diagnosed or comorbid with both disorders, or have this tic-related OCD. So it's kind of hard to disentangle, but this is what we aim to do in this IOCDF-funded project at the moment, specifically looking at genetics. So I think that's very interesting, hearing what you say about like the clinical part of it as well.
Well, yeah, we're going to ask questions about the genetics in a second, but how do you disentangle these entities clinically? Because I've heard of not just right OCD, which is not typically invoked in the context of tics, but it sounds really similar, where someone just feels like something's not just right. I go make a movement, I correct whatever felt not just right. Now I feel better. And I've talked to people who have just straight diagnoses of OCD who don't endorse any particular fear or thought attached with the not just right feeling. So I suppose, how do you disentangle it and ask questions like Nora's interested in asking?
I guess, John, you want to take that one?
Go ahead.
Okay. It's like you disappeared. I was going to let you take it.
Yeah. I was running away from the question.
Yeah.
That's a good way to
That means it's a good question. I like that.
It's a great question. I mean, I guess like I'm the kind of person who like, I'm like the categories in the DSM, right? That they're our best guess at how we categorize things. They're not like, from a brain perspective, the brain doesn't carve itself into these categories. So we're kind of doing our best, right? So as a clinician, what I'm looking for is kind of trying to step back and look at the bigger picture of what are all the repetitive behaviors someone is experiencing? What are all the kinds of, thoughts that they're experiencing? With, a tic disorder, you'll see a pretty typical developmental trajectory that will kind of be that in early childhood, it starts with these simple tics like eye blinking or nose movements, mouth movements, and then it progresses to the periphery. And usually these complex tics come on later in development. So I would be like looking for that to feel like, okay, there's a tic disorder here. If someone has a lot of these, like not just right complex kind of movements, and they have tics and they don't endorse any like kind of classic harm avoidant OCD symptoms, I'm kind of leaning toward at least their treatment plan starting more like, let's treat this like a tic disorder. If there is a lot of, again, I'm calling like the classic harm avoidant stuff too, and they're both there, I would kind of say both, and let's work on whatever's the most impairing. And then sometimes you have a lot of this incompleteness stuff, but someone just really has no history of these simple tics. So then I would think of it more as OCD. But like John said, there is this Tourettic OCD category that even though it's not like in the DSM, we see it a lot. And then we're just kind of doing our best as clinicians to think about like in our toolkit, what seems like might be the best tools to address the symptoms that are the most impairing for that person. John, do you want to?
Yeah, exactly.
You don't get to avoid it entirely.
No, absolutely. I think that makes a lot of sense. And to be honest, a lot of what we're doing was we're treating at the symptom level. Yeah. And the treatments for tics and OCD are pretty similar. I mean, we use different terms, but they're pretty similar. So we would look at the symptom. We'd want to look at the triggers. We'd want to look at the consequences. Is the behavior being rewarded? Is it leading, allowing the individual to escape from responsibilities, or other factors? Are they getting attention because of it? And we would just really want to address it from a behavioral perspective in that sense. Pharmacologically, it's a little bit different. I mean, the medications are different for Tourette's and for OCD, but there are some overlaps at the more severe levels. And I want to know what the symptom is, but that's not always possible. And if I'm not sure if it's tic or OCD, that's not going to stop me from just doing the best treatment I can do.
Yeah, I mean, it reminds me of kind of a lot of conversations we had on the show where it almost boils down to like, well, it's sort of a academic theoretical difference as to whether or not, like, which bucket a person may fall into. But at the end of the day, someone struggling, we need to look at the symptom and then try to treat them the best we can, like, regardless of, what artificial bucket is best to place them in diagnostically. Are there neurological differences in kind of like how tics arise versus how I might feel if I feel like something's uneven and I want to go fix it because of some harm related thought? Like, is there kind of a brain signature associated with tic disorders?
Yes, we think so. I mean, I'm saying that, like, I can give you kind of the basic understanding I think we have over it. I think it's, again, like, I think it's a really compelling question. I'm really excited about Nora's research too, because I think knowing the genetics of this will also help us understand, like, how does that architect the brain in a way that, like, helps us separate these. But like I was kind of alluding to, I really think of it as three parts of this circuit so it's this circuit called the corticostriatal circuit. So and so basically it's connecting this deep structure in the brain, the basal ganglia, up to different areas of the cortex, so the surface of the brain. So deep in the brain, you'll now have to indulge me with my analogy that I'm very proud of.
Okay. I like analogies for neuroscience.
Yeah, so I think of these like train tracks, okay? And so like in the basal ganglia, I think of it kind of like the train yard. So all of these different tracks are coming together and they're getting loaded up with like neurotransmitters and messages, right? Of like, they're going to get sent out. Then these tracks, like you can imagine, they're going up to this like middle part of the brain called the thalamus, which is kind of like a grand central station, right? Where kind of everybody gets on and then they start to diverge.
Everyone being like all the trains loaded with messages.
Yeah, so it's like all these messages loaded from the basal ganglia, and then it's like, all right, we're going to funnel up to the thalamus.
Yeah, and then they go in all the different directions.
And then they're going to split off. Okay, so then they're going to split off, and you're going to have one track that goes up to motor areas. So areas that control our urges to move and our actual movement output. And so at least in Tourette's and tic disorders, we know that track is like there's too much information. So there's too many movement messages.
Mm-hmm.
Then you have a track that's going out to the front of the brain, which is like our inhibition system, like being able to put the brake on things. And that track is underactive. So there's not enough brake. So it's like too much movement, not enough brake. And then there's also this track that's like our emotion, like fear, the limbic circuit. So it's like an emotion circuit. It's really activated when we're like anxious or sad. And there's almost like a hyper track, like a speed train between that emotion track and the movement track in tic disorders. So emotions have a stronger impact on movement output than in people who don't have it. So this is why like a lot of people with Tourette's talk about like, oh, when I'm really stressed, I have more tics. Or I'm really anxious. So it's affecting those tracks. And then all those tracks come back to the basal ganglia and they're kind of like, okay, here's what happened. And then it's like reloading. And so those are all the same tracks I think of with OCD. And like the interesting thing is in that basal ganglia, like I said, that like part of the brain where they're kind of like the train yard, the like geography of it is that these tracks are really kind of like they're intermixed biologically. Like there's cells that are lapping with each other. Mm-hmm. And so the way we sort of think of it is that like what kind of symptom profile people have really depends on like where exactly in that train yard there are cells that are like over or underactive. And so if you have a lot of activity that's like happening right between the emotion and the movement track, maybe you are going to have tics and OCD, versus if it's just over in the like motion and move and inhibition one, maybe that's driving more of like a Tourette's plus ADHD symptom profile. And so that's where you get into some of the circuit-based treatments that I and others work on, and some of like deep brain stimulation. That's where those things are going into the grand central, into the train yard, right? And sort of we think like where we put the stimulation is going to have different effects on symptoms because of how those are organized. I'll stop now.
Okay. No, that was very helpful. So like at least within the confines of that analogy, it does seem like while clinically they can get very convoluted and seem very similar, there may be some neurologic signs that there's differences, or is that too grand of a statement?
I mean, in terms of like, if you're saying neurological, like the biology is a little bit different, then probably, yeah. Like it probably depends on like where things are happening that affects what symptoms we see. And the other part I kind of left out that I should add though is like the environment that someone's in can also really influence what's happening in all of this. So that's where it does get tricky. But I mean, I think of both of them as definitely they're biologically based conditions that are really impacted by the environment. But unlike something like maybe, some versions of depression that are maybe more highly driven by someone's situation, like tics and OCD are really like biological. They're kind of core, if that makes sense, but maybe in like slightly different ways.
Yeah, and Nora, I'm curious, like, what do you think when you're hearing all this, thinking about the genetics of these potential differences or similarities?
Yeah, just with regards to what kind of genes we found. So OCD genetic research is a bit further along than tic or Tourette syndrome genetic research, just because kind of the sample sizes that we currently have. But we do see some overlap in the signals that we see, not specifically in the genes that we pinpoint. We still kind of have to make sense of those genes as well, but kind of where these genes are enriched in the brain. So usually when you run an analysis, you find like some gene points, and then you try to make sense of them and also see where actually in the body do those genes play a role, because we have the same genetic information in every cell, but a hair cell is very different from a brain cell. So we kind of want to see where do these genes actually play a role. And we do see a lot of the areas that Christine was talking about that play a role in both disorders, that we also see genes that are involved in these brain regions actually coming up in these studies, but not in that specific kind of way where we can say like, oh, this makes more sense for Tourette's and this makes more sense for OCD. So it's very blurry what we find. So we can't really pinpoint exact, oh, this makes sense in this part of this pathway and this makes more sense in this pathway. So it's still a little bit blurry, but those signals that we do see make sense with kind of the overall neurobiological understanding of those disorders, which is nice, encouraging. That's not contradicting what we've seen from other areas so far.
John, I'm curious if you have any thoughts on kind of this more biologic understanding.
No, I agree with everything that's been said so far. The one thing to think about though is every individual is different. I mean, the brain is so complicated in the genetics, so it's we're not at the point yet, at least I don't think we're at the point yet, where you could just do like a brain scan and diagnose somebody off of that, or look at somebody's genetics and say this genetic profile means that you have OCD or Tourette's. It's these findings are very, very subtle, and the brain and genetics and the wiring and all is so complicated. But we know so much more now than we did even just a few years ago, and it's really exciting to think where this is going to go. And the work that Christine is doing, looking at brain-based treatments, I think is really exciting. And the genetics also, Nora's work, I think is going to be really important in helping try to disentangle some of these things. Because if we can get a better understanding of the genetics and how the genetics and the brain architecture and function works, that's going to be really, really amazing to help us with this work in terms of prevention and treatment.
Yeah, I'm definitely going to be asking more questions about the brain-based stuff or brain-based treatment that Christine alluded to. I, though, am still confused as to like the extent to which these, can be separated at all levels that we've discussed so far. And there's questions in the chat that kind of allude to a similar confusion. So I want to address those and then just kind of have you guys take a stab at them. At 12:15, Wiley, I'm sorry if I pronounced that wrong, said, is tics with OCD equal to Tourette's, or what's the main difference? So if you could just kind of summarize everything we've spoken about for 30 minutes for Wiley, I would find it helpful too.
I can take a crack at that if you'd like. And I'd be interested to hear what Christine and Nora have to say as well. So tics plus OCD is not Tourette's. Tourette's is a combination of motor tics, which would be like arm, body, leg, head movements, and vocal tics, which would be making noises, like anything that you would make with your vocal cords, snorting or airflow through your mouth and nose, snorting, sniffing, words, screaming, yelling, whatever. Tourette is a combination of both of these motor tics and these movement tics and vocal tics. So Tourette's plus OCD is just a common comorbidity. We would diagnose both disorders and say this person has Tourette's and this person has OCD. When you get this kind of interface between the two, because they're very similar disorders, then you would either have like not just right OCD when it's sensory triggered. I get a feeling something's not quite right. It seems a little more like motory or kind of behavioral. That would be either Tourettic OCD, or we might call it sensory OCD, or sometimes even sensory tics. That's a separate kind of a disorder. People don't really think of it as one disorder. They think of it, there's some pieces of OCD and maybe some aspects of Tourette's as well. But no, OCD plus tics is not Tourette's.
Okay. That's what I thought the answer was.
Yeah.
And then I'll throw this.
And it's probably also not just OCD. Oh, sorry, my internet is lagging in between. Sorry if I interrupt you.
No, continue.
I was just wanted to add, and it's probably also not just OCD. So there was one study that looked at individuals with tic-related OCD. I'm not 100% sure how they defined it, whether it was kind of both symptoms at the same time or just individuals that had both diagnoses in their lifetime. So I'm not entirely sure about the definition of their tic-related OCD, but they compared, I think it was quite a big study, around 1,300 individuals with tic-related OCD and about 20,000 individuals with only OCD. So, well, not only OCD, but not tic-related OCD. And they kind of looked at different aspects of these two groups. And they did find some differences. For example, when they looked at the relatives of those people with tic-related OCD versus the relatives of non-tic-related OCD, they found quite a few more relatives that also had OCD in the tic-related OCD people than in the non-tic-related OCD people, which kind of points to it might be more familial. It might also be just more severe, and that's why you have more familial vulnerability and more genetic risk factors maybe influencing it. And they also found some more like descriptive differences, that tic-related OCD is generally diagnosed earlier than non-tic-related OCD, and that you have different patterns of kind of comorbidity in those groups as well. So that people with tic-related OCD tend to have a higher co-occurrence with epilepsy, ADHD, and ASD, where those people without those tic-related or with not tic-related OCD had more like mood disorder, anxiety, bipolar disorder comorbidities at the same time. So it's also probably, it's neither only tic nor is it only OCD. So there might be something going on that is really distinct for these tic-related OCD people.
That's super interesting, and it kind of lends us up to another question: is are folks with OCD plus tics, does their OCD tend to be more severe, just like quantitatively or qualitatively?
No.
Christine shaking her head.
I'm trying to remember back to now a paper I wrote a very long time ago where so there was in the pediatric OCD study, the POTS trial, the first one that compared exposure therapy to an serotonergic like SSRI medication alone to the combination. Mm-hmm. In that first study, they found that people who had tics and OCD responded equally well to therapy, but responded more poorly to the SSRI alone. But they weren't more severe in their OCD. And then we followed that up in the POTS-2 study. So that study was looking at kids who had already been on an SSRI, but who didn't have a great response. Like they still had a lot of OCD symptoms. What's interesting is a lot more of proportionally, a lot more of the sample in the POTS-2 study had tics. So, which kind of makes sense, right? If you think we know that if you're on an SSRI alone and you have OCD and tics, your OCD is not going to get as much better. as if you only had OCD. And so it's kind of like more people with OCD and tics aren't responding as well to an SSRI, not that they have more, their OCD severity is higher. So that's kind of how I think about it, is more like I kind of talked about earlier, like our treatments don't seem to tap as well the combination, but
Right.
the OCD symptoms aren't necessarily worse. So you do see, like, as you get to like what we would call like more and more treatment resistant OCD, it is common to see more people with tics because they tend to have more of these symptoms that, like, again, like incompleteness, not just right stuff, is a little bit harder to tackle with exposure therapy. Like, it doesn't it's not this fear extinction learning that you see in harm avoidant OCD. Interestingly, some of the newer like neuromodulation treatments like transcranial magnetic stimulation, or TMS, that targets some of those circuits I talked about, the people with OCD who do better with that are the ones who have tics. So it might be that we just like need different treatments depending on whether you have OCD and tics or OCD without tics.
Okay, that's really interesting. And really confusing.
Yeah. I may have explained it poorly too, but
No. I don't think you did. I think it's a confusing topic. I don't know if anyone else has anything to add before I pepper another question in.
Yeah, I can add just a little bit. And I think very similar to what Nora was saying from the genetics, the family genetics, and Christine. I mean, tics and OCD overlap in terms of some of the comorbidities that they have, but they also tend to be somewhat different in terms of the rate. So individuals with Tourette's are more likely to have ADHD or maybe externalizing disorders, more behavioral problems. Autism spectrum is a little bit higher relative to OCD. Individuals with OCD can also have ADHD and may also have, be more likely to be autism spectrum, although the rates are pretty low.
Mm-hmm.
But they're more likely to suffer from anxiety and depression and maybe eating disorder. So you have different comorbidities or complexities. So when we're treating somebody, comparing the treatment of OCD and the treatment of Tourette's, it's just not those two symptom clusters. It's all the comorbidities and other factors that go along with those that can lead to complications in different rates. I think Christine described that really nicely.
So I suppose one question that I have is, and I'm glad John's not here because he would hate that I'm asking this question. Is there like a sense as to why people with TOCD or OCD with tics, actually, let me take a step back and actually ask what Amy asked at 12:35. Is the mechanism of Tourettic OCD different than the mechanism of comorbid Tourette's and OCD? Are those different things, or is that the same reference to the same thing?
Well, you can have, I'll answer it clinically. I'd be really interested to hear what Nora has to say. You can have Tourette's and OCD and have kind of straightforward Tourette's and straightforward OCD. It doesn't mean, just because you have symptoms of both doesn't mean that you're going to have this Tourettic OCD that's not just right. We've seen some kids that have harm-based, harm avoidance. I'm afraid I'm going to get sick if I don't wash my hands, and I also have some tics. It's a continuum.
Mm-hmm.
There's some with extreme symptoms, the prototypic tics and prototypic harm OCD symptoms in the same picture. And then there's some that are really in the middle at that overlap between tics and OCD, where it's more like Tourettic OCD or not just right.
Oh, yeah. So it kind of depends on the extent to which they overlap. Because you could just have both disorders totally separately.
Right.
Yeah, and I think go ahead, Nora. Yeah.
Go ahead. You go ahead.
I was just I think the piece that John said that I want to highlight is it's really about this, like, is there this cluster of symptoms that's really like a lot of movements that look voluntary that are driven by these like really sensory experiences. That's more like what Tourettic OCD kind of looks like versus what he's saying, like the classic harm avoidant OCD and classic tics that are just maybe more like simple movements that,
Yeah, I don't have a good answer to that genetic wise, because it's so hard to kind of disentangle that, because I don't collect the data myself. So I'm dependent on clinicians that collect the data, and then I get the data and kind of try to make sense of that for genetic studies. And it really depends. There's so many different ways of how these data sets are collected. And in genetic studies, our effects are usually very small. So we need the biggest amount of data that we can get. So we're really dependent on large sample sizes. So for example, in our recent Tourette or tic disorder genetic study, we had 10,000 people with tic disorders, and in OCD we had 50,000. So really just lump kind of everything together. And there is this ongoing debate of whether more is always more, or if you should kind of, if as a field we should also start to invest more and more into like more the deeper phenotyping. So having more kind of data points than just, is someone diagnosed, has ever been diagnosed with a disorder or not? But it really depends on where those data sets come from. So sometimes it's just clinical, it's like in clinics, clinicians collect this data. And then sometimes we have, especially in the Nordic countries, in Scandinavia, we have these huge databases where people kind of patient registries. So that data can look very differently. And then we often have very minimally phenotyped data sets as well, where people kind of in an online questionnaire get asked, have you ever been diagnosed with? So it's sometimes hard to actually get this data to actually answer those questions, because we don't necessarily know whether people have OCD and some tic disorder at the same time, whether they have tic-related OCD, sometimes we don't even know if these diagnoses were present at the same time or not. So it's really hard to disentangle this. And it's in genetic studies often kind of lumped together. And yeah, that makes it difficult to answer those very specific questions. I'm happy to kind of find the similarities or differences in OCD and tic alone. And that's hard enough because they're so comorbid as well. So in our OCD genetic studies, we have lots of people with tic disorders or any other psychiatric or other disorders. And also now look at the genetic correlation. So when we kind of compare the genetic basis of those two disorders, we see a large overlap, about 50%. But of course, we don't necessarily know where that overlap is, like which genes or which genetic risk overlaps, and whether this is really just because, or at least a part of it is because we have OCD, people with OCD in our Tourette GWAS, and we have people with Tourette in our OCD GWAS, and that kind of makes it more similar. So it's hard to disentangle that.
Mm-hmm. Okay, so if I could summarize, just because I'm sure a lot of people watching the stream would like a summary to this point. Clinically, they can appear separately in a case where someone may have Tourette's and OCD, or they can appear like tic-related OCD, which I think is also called Tourettic OCD, where they seem related in some way, and a tic may present as something where you're trying to even something out or correct this kind of just right feeling, which looks a lot like OCD. Genetically and neurologically, some similarities, some differences. And then treatment-wise is what I want to get to now, because it seems like the treatments are similar, but also different. So how do we treat Tourette's and how do we treat OCD if they're separate and same patient, but functionally not related?
I can start with that, I guess. To back up a little bit, the way I think about this is that OCD and Tourette's are pretty similar in terms of the mechanism of treatment. So in OCD, I have a scary thought. I'm afraid if I don't wash my hands, I'm going to get sick or I'm going to make somebody else sick. And that makes me really anxious. I wash my hands and I feel better. I do my ritual or compulsion and I feel better. So every time I wash my hands and I feel better, what I'm learning, I'm teaching myself that was a close call. Something really bad could have happened. I'm glad I washed my hands. I'm strengthening my fear. I'm strengthening my belief that something bad could happen, because when I wash my hands, I feel better and it reduces this risk. That's called negative reinforcement. Positive reinforcement, if you get an A, if you do well on a test, you get an A and it's really good and you feel good about yourself. Negative reinforcement is if you have a bad feeling or something bad and you make the bad thing go away, you also feel good. So if I can make bad things go away, that's as helpful as making good things happen. So with OCD, I have a bad feeling, I do something to make it go away, and I say, I'm glad I washed my hands. I want to wash my hands all the time because it makes me feel better. It makes the bad thing go away. Tourette's is almost exactly the same. I have an urge or a sensation or a pressure or a feeling. I don't like it. It's quote unquote bad. And I do my tic and I make that bad feeling go away, that sensation go away. I have tension in my arm. I just want to move my arm out, and I put my arm out, and that makes the urge go away. I feel better. It's the same thing. I have either a bad feeling or a bad sensation. I either wash my hands or do my tic. I feel better. The treatment is breaking this relationship. The treatment is for OCD. When you have the bad feeling, don't do your ritual. Don't do your compulsion. Sit with the bad feeling. And eventually the bad feeling will go away. I'm afraid if I don't wash my hands right now, I'm going to get sick. I'm going to get deathly ill. Well, don't wash your hands and let's see, did you get deathly ill? No, you didn't. With the tic, I can't stand it. I need to move. And if you do the treatment that we use, it's called habit reversal training, is every time you have an urge to tic, you cross your arms, you make a fist, you do something to prevent the tic from occurring, just holding it back. So maybe I'll hold my arms like this together instead of making my arms fly out. And after a short period of time, the urge to tic will go away. In the same way that with OCD, the feeling that something bad will happen go away. So it's the same treatment basically, except we're targeting the urge tic, and the urge to tic and the obsessive thought are the same, and then doing the tic and the ritual are parallel as well. So I don't know if that was clear or not, but that's the parallel nature of the two treatments.
Yeah, I suppose like one thing that's kind of confusing to me is I had always conceptualized tics as something that were different than behaviors in OCD insofar as they were harder to control. Like they were more involuntary. Is that not the case?
That is, they can be involuntary, but you still can learn to manage them. They're not involuntary, they just happen automatically. They're more automatic behaviors. But the same thing, somebody with OCD that is worried about something and may counter tap or something to make the bad feeling go away. You see in OCD, the behaviors become automatic after a while as well. People don't even think they're doing them.
Yeah, I agree, John. There's like some really interesting, stuff in the OCD literature about like maybe OCD really is at its core more of this like motor like habit disorder, and the sessions or something that kind of gets added later, but it's really this loop. I mean, to give an analogy, I think of tics being voluntary and involuntary in the same way our breathing is voluntary and involuntary, right? It's like an automatic behavior, but you can exert control over, like, when you focus on it, you can control how deep you're breathing, how fast you're breathing, your pace of breathing. And tics are kind of like that. Like, yes, it's involuntary, but you can exert some like inhibition over it that changes how it plays out.
I mean, some individuals, when they're in public places with tics, they're able to hold their tics. They'll say, yeah, I was in a public place. I was in church. I was in a movie theater. I was at my graduation, and I was able to inhibit my tics or hold my tics in for an hour or even 2 hours, but it was really, really hard.
Mm-hmm. Yeah, what's interesting is we have some newer data in the lab where we were kind of looking at this question of like a lot of people report that they are inhibiting more in front of people, and so we wanted to look at that. So we actually watched videos of people in our clinical trial of Tourette's when they were with a clinician being interviewed and like talking about their tics and talking about their mental health versus when they were alone in a room. And what we find is actually that people have 600% more tics when they're by themselves.
Wow.
And so, but a lot of them will report their tics are worse in social situations. And so the brain is doing these interesting things, I think, not entirely within people's conscious awareness. To like, we're kind of calling it, and our colleague Kevin Black at WashU has seen a very similar thing in his data. And so what we're kind of thinking about is maybe there is this, we're calling it like a social automatic tic suppression that like folks are learning, like John was talking about these, like the reinforcement of like, when you're inhibiting tics, you may not be the center of attention, or you might be able to avoid like people saying things to you that are uncomfortable. Over time, the brain is like just automatically maybe putting on a break in those situations.
Yeah.
So it brings, I mean, Kyle, I love your question, because I think to me it's so interesting, even this idea of like what is voluntary and involuntary is just like so interesting of, you know,
Yeah.
these things.
I mean, that's also like mind-blowing that people see far more tics when they're alone, but they report experiencing more in social settings. Which like that would imply to me that like their brain is engaging in unconscious like suppression of these tics. Does that sound?
Yeah, like I think of it, we've been talking about it a lot in the lab, and I mean, I'm sure it's true of compulsions too, although I don't know if anyone's done it, but we were kind of talking about how, you know, how like whenever you're by yourself, you're less inhibited in general, like, you know, you might like scratch your nose or like, you know, squeeze out a fart or something, right? When you're alone.
That's
But,
me, never. Come on.
yeah, right. I mean, I'm confessing something here, but right, like we are generally like our inhibition system is like we let go when we're by ourselves. And like when we're around people, we're not constantly walking around the world like thinking, oh, I'm not going to do, you know, my tics or my rituals or pick my nose. There is some process that's just like happening out of our awareness, but that has been, it's there because we've learned something from our environment.
John or Nora, do you know if that's like the case in OCD, if there's like an analogous study? Out of curiosity.
I don't know, to be honest.
I clinically, I know it happens.
Yeah.
I mean, you know, when people are in public, they work really hard to not do their rituals. And a great example is we have kids coming in. I work mostly with kids, some adults, kids and adults. They come into the clinic for their initial evaluation, and they don't do any rituals. Sometimes they don't do any tics either. And you say, it's okay, relax, you know, show me your obsessions, you know, show me your rituals. We're all, you know, we are wired, you know, to behave certain ways in public. And then when we get home, you don't want to see me watching TV when I'm by myself, man. I'm sprawled across like 3 couches. But I would never do that like in a lecture, you know. I mean, it's just human nature. Our brains are really sophisticated in terms of knowing when to inhibit and when not to inhibit.
It sounds like you're just going to lecture halls that don't have very comfy couches, John. That seems like
maybe that's what it is too.
What are kind of like the outcomes for folks with Tourette OCD engaging in therapy? I guess I don't even know what the terminology would be. Is it the ERP for Tourette OCD? Is it habit reversal therapy for TOCD? Is it a pointless question because, you know, it's just nomenclature? And then like what's kind of the outcome for TOCD versus just OCD without tics?
It's yes and yes. It's usually a combination of both.
Okay.
So we you know, I'd be interested to see how Christine, what you do in your clinic. And in our clinic, you first of all, you need to identify the symptoms as such, you know, that this sounds like it's more Tourettic. Is we need to be a little more careful. We can go a little bit slower. We know it's going to take longer for the patients to be able to not engage in their rituals or
why is that? Just to be fully explicit.
Because with OCD, with harm avoidance OCD, and Christine alluded to this earlier, we're trying to break this connection between this fear that if I don't wash my hands, something bad is going to happen. There's an expected outcome. You know, in harm-related OCD, it's like, I believe something bad is going to happen. And that's why I need to wash my hands. And that's fear-based. And the treatment that we do for that is more of something called an inhibitory learning. We want to create new information. Well, let's see, you have a predictable outcome. You believe that if you, you know, take a bite of this food that you are going to choke within 5 minutes. That's a hypothesis we can test. Take a bite of the food and I'm going to put my timer on and let's see how long you go. And lo and behold, I'm still alive after 5 minutes. And by repeating that, our patients are learning new, I guess this isn't as dangerous as I thought.
Yeah.
With Tourette OCD, it's not really a feared outcome. It's just an intolerable state. Like I'm itching, I'm covered with bugs. I have these sensory things that I need to do. Those don't habituate. There's not a specific hypothesis that we can test. So it really is more of just trying to teach the ability to tolerate these uncomfortable feelings. And that takes a little bit longer. So when we're doing these, we may do sensory techniques. We may teach breathing techniques. We may use other strategies to help the patients manage these very uncomfortable sensory feelings. And since the sensory feelings don't necessarily go away after a while, and we can't really break that connection, we're really teaching in some cases more tolerance of the discomfort rather than trying to get rid of the discomfort completely. And it's a little bit of a different approach. Not always. Sometimes we are able to kind of create new learning where the patients are able to disconnect the discomfort from their urge or their sense. But it's a little bit more complicated than that, a little less clean.
Yeah, and just to add, I mean, one direction I'm really excited about for new treatments are ones that are more specifically targeting this sensory piece that John's talking about, because it's a little harder to touch with exposure. So that's where some of this TMS treatment. So TMS is an approved treatment for OCD in adults. And we're testing it out in kids with Tourette's and in kids with OCD. And the circuit that we're targeting is the one that underlies this urge to action. So the spot in your brain that sort of activates when you feel like you need to move and do something to feel better. It's that message lives there before it goes to the movement output. So I think it is a place that we're very interested in for novel treatments, because it's a little trickier in the ways that John described to treat with therapies that we have now.
And I mean, as we're kind of approaching the end here, what's kind of the initial look at TMS and DBS for Tourette's OCD? What are some of the outcomes that we see?
Well, like I said, there's one small study in adults with OCD that showed that there was a better response among the adults that had tics and OCD than just OCD alone. I think it's really exciting that it's now an FDA approved treatment. So we're hoping that people are still having trouble getting insurance to approve it. So once we kind of clear some of those hurdles, I think we're all excited to see what, how it looks in larger populations. My OCD study with colleagues at Brown University is ongoing, so I have nothing I can say about that. But our Tourette study, we combined the habit reversal therapy John was talking about with TMS to sort of say, can we help the brain get something more out of it? And we do find that it changes that circuit in the brain that I talked about, so it's reducing activity in that sensory motor circuit.
Cool.
And it's improving urges. So people who are getting that stimulation have lower urges to tic than the ones who get a placebo.
While also doing
yeah.
Well, that's awesome.
Yeah. So we'll see. We're about to start a second phase that will be bigger and let us kind of look more at how well it's working on other ways. So
may I ask, are those prolonged effects, or do you stimulate once and then this kind of effect holds for a little while, or how long do you see this?
Yeah, the treatment is 10 days. So it's 10 days every day.
Okay.
And then we followed kids in this phase of the study out for 3 months. And in the next phase, we'll follow them out for 6 months. And our brain imaging data is just right before and right after treatment. So we'll get more data in the future on is this effect sustaining in the brain?
Yeah, Nathan asked in the chat, what kind of doctor do I want to be? I want to be a psychiatrist, and I think it's because of that kind of stuff right there. Because I think the brain has a lot of cool answers to a lot of these problems that we discuss on the show. Before we go, I want to give you each just a chance to say a sentence to the audience, to people from the IOCDF or from the Tourette Association of America. Just what you want them to take away from a stream like this. And I'll start with you, John.
I think this has been amazing. This has been really a great talk. The thing I want to say is that these can be really difficult disorders to have. And I know some people have sought out treatment. Some people have done well in treatment. Treatment doesn't lead to cures. although we can get really great outcomes, not everybody's able to do treatment. Some people are afraid of doing treatment for various reasons, but we have good treatments that work. We can help you. And if the first treatment doesn't work, we have the second, third, and fourth. So please, if you are considering treatment for yourself or a loved one, give it a try. I know it's difficult to find therapists in a lot of places, but IOCDF and Tourette Association have really great provider lists. You can go on the websites and you can identify providers, but we are here to help and make your life better for you or your loved ones.
I can confirm that it's can be a rocky beginning to treatment, but it can work wonders from the personal experience of having OCD. Nora, what are your parting words?
Yeah, maybe I come more from the research point of view. Thanks to everyone who considers just participating in these studies, because that is the only way we can actually do this research and understand those disorders better. And yeah, thank you for everyone who participates, also who's here and is interested in the research we do. And I think this is a great platform, and I was really happy to be part of this. Thank you.
I also can concur. Research is cool. And Christine, you're
I mean, mine kind of combines the two. I want to, just put a plug out for I love these conversations for us as scientists to get to really connect with the community. And so, please see us also as people that want to hear from you about what research questions do you want us to be answering that will help your lives. And really value the participation, like Nora said. Both the IOCDF and the Tourette Association have parts of their website that list research opportunities, and we as scientists, we want you to tell us how to help your community, and by participating, that's a really good way that you can help us. So thank you for being here and for having me.
Yeah, thanks. Thank you all for joining. Thank you everyone for watching. Big shout out to the Tourette Association of America for joining the IOCDF in this. And we will see you all next month.